Hi, everyone. My name is Laura Milko, and I would like to thank the organizers for the opportunity to talk about the development of an age-based semi-quantitative metric, or as we call it, the ASQM. The ASQM was developed by the NEXUS binning team at UNC Chapel Hill, and since it's been published, we've been engaged in some efforts to utilize it in evaluating actionable conditions for inclusion in newborn genomic screening. This group obviously needs little in the way of introduction to the historical underpinnings of newborn screening. However, I like this figure from the 2015 paper by Berg and Powell because the y-axis depicts dramatically and logarithmically the number of conditions that are currently screened for and the number of conditions that can potentially be screened for with the adoption of newborn genomic screening. As we know, this idea isn't novel, but it hasn't happened yet. And we believe that deciding which conditions we want to screen for and the ambiguity around the process of decision-making itself are sources of significant uncertainty that are delaying the application and implementation of genomic sequencing to screen healthy newborns. So what is certain is that genomic sequencing has arrived, and health systems in the US and other countries have begun integrating it into disease prevention and patient care in healthy populations. In the direct-to-consumer arena, enhanced newborn screening is being aggressively marketed to new parents who understandably want the best for their new babies, though evidence of clinical actionability and clinical utility vary by offerings. Some of these DTC panels can be ordered through a pediatrician who also receives the test results and coordinates any follow-up care. However, customers can also independently order and receive the results of these tests entirely through the company. And these various workflows really raise a lot of questions, chiefly among them, are pediatricians prepared to return these potentially ambiguous results? And will parents seek out genetic counseling if they happen to receive unexpected positive results? So what we propose is that a collaborative, transparent, and evidence-based approach to knowledge integration that incorporates a wide variety of input from multidisciplinary experts in various sectors who have clinical utility and outcomes data is an important piece of the plan to help us usher in an era of effective, equitable, and evidence-based newborn genomic screening. So here's just an outline of my talk. For the remainder of the time, I'll talk about how we address this conundrum in the NEXUS project and the context and development of the ASQM, its age-based methodological framework, and our scoring criteria for medical actionability. And then I'll wrap up with an overview of the work we've been doing to apply the ASQM in different contexts. So many of you will recall that UNC was part of a 4-site NIH-funded InSight consortium that was established in 2014 to explore genomic sequencing in newborns. And NEXUS, which stands for North Carolina Newborn Exome Sequencing for Universal Screening, was led by Dr. Cindy Powell and Dr. Jonathan Berg at UNC in collaboration with Dr. Don Bailey and a team from RTI International. So each of the 4 sites that were part of the consortium used a unique study design to investigate the application of genome-scale sequencing in newborns for both diagnosis and for screening. If anyone's interested in reading more about the consortium and the site, there's a citation for the NSIGHT marker paper at the bottom of this slide. As part of the NEXUS study design, we wanted to ensure that everyone who consented to sequencing had access to results about their child's childhood onset, highly medically actionable conditions. So this is what is in green over on the left side of the screen. On the other hand, we knew we did not want to analyze or report on adult onset less actionable or non-medically actionable conditions to anyone due to existing and well-founded pediatric principles about decision-making autonomy. Then in the middle, there's this additional information we thought might be of interest to some parents. The childhood onset low or no actionability conditions, the adult onset medically actionable conditions, and also carrier status for recessive disorders. So to start subdividing the conditions into these categories that we wanted to study, we started with two axes. So we started with an age-based x-axis and separated childhood onset and adult onset conditions at the typical age of majority because of the aforementioned principle of preserving future autonomy of children who are undergoing genetic testing. And then we were also interested in categorizing conditions based on their medical actionability. So we adapted an existing evidence-based and standardized semi-quantitative metric to use for scoring actionability. We knew from our previous work that there would be a threshold above which would be highly actionable conditions that we could also categorize by early age of onset and intervention. So next, I will discuss our scoring criteria and consensus decision-making process for categorizing conditions and their associated genes, and some of our results and our validation work using the RUSP. So this is the semi-quantitative metric, or ASQM, we used for the NEXUS project. It's based on 5 criteria that we consider fundamental to medical actionability, each scored from 0 to 3 for a maximum possible score of 15. For each gene disease pair, we scored the severity and likelihood of manifesting a particular condition, the efficacy and acceptability of intervention, and the overall knowledge base of the gene disease association. We realized that people will have different concepts of medical actionability, but we developed this scoring rubric after much deliberation and made a very concentrated effort to be transparent about it. So our first criterion, severity, assesses the nature of the adverse health impact. Scores range from modest morbidity, which has a limited impact on health and quality of life, to sudden or unavoidable death in childhood. Likelihood assesses the chance that the outcome of interest, which is the same outcome as was scored for severity, and generally we scored the most severe, it measures the likelihood that that outcome will manifest. Likelihood is akin to penetrance, but maybe focused on a particular phenotypic aspect of that condition. Efficacy assesses the extent to which clinical interventions can prevent or mitigate adverse health outcomes, and were based on published evidence and, when available, specialty area clinical expertise from our multidisciplinary committee. Due to broader consideration of condition-wide outcomes and potential for interventions, our scores reflected the ability of available interventions to impact total condition-related morbidity. So in some cases, this meant that an intervention described a general approach to surveillance and early management of symptoms by specialists. And in other cases, we evaluated a specific treatment, for example, a hematopoietic stem cell transplant. Acceptability assessed the quality of life burden associated with that specific medical intervention. Again, scores for this criterion reflected the possible cascade of evaluation and treatment that most newly diagnosed and/or pre-symptomatic patients would experience, but was weighted by the likelihood that an individual who was identified through screening would have to undergo that entire cascade of interventions. Sometimes the acceptability score then reflected a specific treatment that would be recommended, like for instance, a dietary intervention for an inborn error of metabolism, while in other cases, the acceptability score reflected something like a process of surveillance, but not the definitive management. So an example of this would be children identified as having SCN1 variants consistent with Marfan syndrome. They would all undergo regular cardiology evaluation, but only those that would progress to an aneurysm would require a surgical intervention. Finally, knowledge assesses the evidence base supporting the scores that were assigned in the other categories, including the validity of the gene-disease association, the natural history of the disease, and the ability of recommended interventions to effectively prevent or mitigate the condition, particularly if detected early, as would be the case with newborn screening. So this slide illustrates our workflow for curation, scoring, and classification. So we had trained staff biocurators who reviewed the primary literature and the primary resources, along with curating the natural history, treatments, interventions, and evidence linking the gene to the disease. A primary reviewer was then assigned to review the curated evidence and present it to the larger multidisciplinary committee, along with suggested preliminary ASQM scores for each of the criteria. The committee discussed the evidence and then also participated in discussions that ultimately led to consensus scoring and classification. So here again is our quadrant framework, separated on the dimensions of actionability and age of onset and intervention. And based on validation work from our previous use of a similar framework, we set an actionability threshold of 11, which then created our 4 categories. Category 1 up here in the upper left quadrant represents the NBS panel that contains highly actionable pediatric onset conditions that are analogous to the current newborn screening conditions. Everyone who was consented to join the study and consented to have their child's DNA sequenced received reports of pathogenic and likely pathogenic variants for genes in Category 1. Category 2 contains pediatric conditions with low or no actionability. So because semi-quantitative scores are by their very nature fairly coarse and fall along a continuum of actionability that's not simply black and white, gene disease pairs that scored between 9 and 11 required a further discussion and consensus decision about whether they belonged in Category 1, the high actionability NGS NBS panel, or out and placed in Category 2 for parental decision making. Because of the way that we constrain some of our semi-quantitative criteria, some of the conditions that scored a 9 were obvious candidates for inclusion in Category 1, and several that scored an 11 were clearly more appropriate for Category 2. So parents who were randomized to a decision arm had a choice about whether to learn results from Category 2 as well as Category 3, adult conditions with high actionability, as well as carrier screening for autosomal recessive conditions. And then Category 4 conditions, which were adult onset conditions with low or no actionability, were not analyzed or returned. This slide illustrates a couple of examples for our scoring rubric. So if you look over in the far left column, you'll see our 5 criteria. And then PKU is in this first column. The scores are in the first column. The description of our thought processes for the scores are in the next column. And obviously PKU is the classic example of a condition that's found on the RUSP. It's a high scoring condition that was unsurprisingly placed in category 1. So here we scored severity as a 2 because our committee decided early on that severe neurological involvement could be equated with possible death. The likelihood of severe intellectual disability is almost 100% for untreated PKU, and the PKU diet is highly efficacious at preventing it. The acceptability of the PKU diet scored a 2 from modest acceptability because while it's not as burdensome as, say, the removal of an organ, it's still a lifelong and highly restrictive diet, and it incurs a substantial burden. Knowledge was scored at a 3 because a lot is known about this condition, including about the efficacy of the treatment, and there are practice guidelines for its management. So over in this next column, compared with PKU, Tay-Sachs disease is a devastating and fatal childhood condition with no currently efficacious intervention, and therefore no score for actionability either. There is a lot known about this condition, so ultimately it scored a total of 9, and it was placed in category 2 as a pediatric condition with low or no actionability, for which parents who were randomized to the decision arm did have the opportunity to choose to receive. In total, we scored 822 gene disease pairs. So I'm looking at the left side of the screen. We scored 822 with pediatric onset of disease and suspected actionability with a RUSP, and this is represented in this plot over on the left. Of these, we classified 466 in the category 1, which is that top left category for childhood onset and highly actionable conditions that are analogous to the conditions selected for the RUSP core panel. We classified 245 gene disease pairs in our lower left category 2, which have childhood onset but low or no actionability, and 25 were classified in category 3, which is our upper right category of our framework, as having adult onset and high actionability. And then 19 were classified in category 4 in the lower right quadrant as having adult onset but low or no actionability. For those of you who are faster at mental addition than I am, the remaining 67 were excluded due to controversial evidence and/or prenatal onset. Then we compared our final scores for the RUSP primary and secondary conditions to evaluate the ability of the NCNEXUS categories to reliably represent the pediatric actionability of monogenic conditions. So over on the right, this box and whisker plot represent our ASQM scores for 34 genes related to 25 primary RUSP conditions. Of those, 32 were placed in category 1, and 2 were assigned to category 2, and then 35 conditions that were related to 22 secondary RUSP conditions. And of those 22, 18 gene disease pairs were assigned to category 1, and 15 pairs were assigned to category 2. So overall, the high ASQM scores assigned to most RUSP conditions confirm that we're generally very well able to capture actionable conditions. So at this point, I'd like to wrap up with some of the recent work and some planned future work to apply the ASQM framework. So this slide shows a snapshot of some of the commercial offerings that are available right now. And it's not always clear what's included by looking at the website. we thought it would be an interesting use of the ASQM to analyze the direct-to-consumer offerings. And we had a former ASQM curator and graduate student, Daniela DeCristo, who volunteered to look at 4 DTC newborn panels that were available about a year ago that included baby genes, Fulgent, Semaphore, and PerkinElmer. Most of the offerings from these 4 commercial entities included about 100 to 250 genes. The baby gene newborn panel claimed to be all exclusive, and it included 100 genes. Semaphore's Natalis panel offered pharmacogenic results for 40 different genes, and Fulgent offered more than 250 genes. Among other offerings, PerkinElmer offered the NeoSeq newborn and pediatric gene panel, and it had the distinction of offering almost 1,500 more genes than its competitors. And so that really led us to wonder, with new clinical trials entering the pipeline constantly, would we end up with something like an arms race situation, similar to what's happening with the current diagnostic gene panels, where companies are competing to have the largest and most all-inclusive newborn screening panel without regard for clinical validity and clinical actionability. So a lot of this potentially confusing and possibly misleading information, we think really has the potential to create complex situations for both pediatricians and consumers. And it really underscores the urgent need for an evidence-based and transparent method of deciding what we should screen for, that is also informed by the perspective of parents, providers, as well as public health experts. Transitioning to reviewing the scores for those 4 clinical offerings, overall they were high, though there was a much wider distribution of scores than the NEXUS Category 1 or the RUSP. There were some very low outliers in the PerkinElmer and baby genes panels, including 23 conditions with currently low actionability scores that qualify for placement into our lower left Category 2. There was a Category 3 that was an adult onset high actionability condition, and also several Category 4 conditions with adult onset and low or no actionability. So though the commercial offerings generally look like a good start, the panels really deviate wildly from a highly selected and actionable gene list and don't meet the standards of the RUSP or the NEXUS program. And this raises some significant implementation issues for routine pediatric care. As more consumers can and begin to purchase these offerings and then bring the results of their child's testing to their primary care physician, there's a very real risk of overburdening pediatricians who are already very, very busy and generally lack the resources to educate parents. So one strategy that could potentially mitigate the impact of implementing newborn genomic screening on primary care providers is to characterize conditions by actionability into distinct age-based panels, perhaps focusing on those with the highest ASQM scores and strong or definitive clinical validity scores to provide really high quality and highly actionable information. Analogous to the current schedule of hearing, vision, and developmental screenings, genomic screening panels could be scheduled to coincide with routine pediatric wellness visits at the appropriate age of onset and the age of intervention. They could utilize cost-effective targeted sequencing, and parent education and informed consent could really be tailored to the appropriate time frame with easily discussable packets of information. And then we envision that this process would just naturally extend into continued public health screening in adulthood. So as as we look toward future directions and approaches, the ASQM offers a process to select which conditions we would screen for. Currently, members of our original ASQM multidisciplinary committee have reconvened in a collaboration with the Early Check program that's led by Dr. Don Bailey and Dr. Holly PA at RTI International and Dr. Cindy Powell at UNC to evaluate highly actionable conditions for inclusion in a pilot study of the use of genomic sequencing in the NBS context as an extension of the current Early Check program. As we prepare to utilize the ASQM to evaluate conditions for screening as part of the Early Check program, we're cognizant of the rapid advances in gene therapy and the need to be aware of and responsive to newly approved therapies. So this little cartoon attempts to illustrate what we envision as a pipeline to capture conditions on the cusp of actionability from various sources. A shout out to the NBSTRN. One of their sources is their very useful NBS condition resource, which highlights new conditions that are poised for efficacious new treatments and could require a rapid review in the near future. So we propose that the ASQM provides a framework with the potential to be scaled and made transparent and has the ability to really facilitate the engagement of the larger community of experts in discussing and decision-making about incorporating genomic sequencing into the care of newborns. So in conclusion, I think we all agree that sequencing newborns and infants is a highly promising way to identify early onset conditions and potentially to improve outcomes for conditions that are not currently included on the RUSP. We feel that one of the real barriers to implementing newborn genomic screening is really the lack of a standardized process to evaluate and select the conditions that we want to screen for. And we think that ASQM can be used regardless of the method of interrogating to select conditions for either targeted panels or genome-wide analysis. And then finally, we really do think that medical actionability is the most critical starting point for public health screening. However, we do think it's necessary to think through other topics such as prevalence and economic impact. So with that, I would like to thank the NEXUS bidding committee, particularly Jonathan and Cindy, and our group of core primary reviewers. I'd like to thank our absolutely fantastic curators, and then I would also like to thank our multidisciplinary committee who gave very generously of their time and expertise. And with that, I would be happy to take any questions.